So let me start with a case, and I saw this case 2 days back, and let me read out the history for you. He's a 75-year-old male, has diabetes, he has a rise in creatinine, his at present creatinine is 1.67, he has a blood pressure, but he's on and off on medications, no cardiac issues. He had a clear cell RCC for which his right kidney was operated in 2016, and after that he has received no adjuvant therapy. He is occasionally he takes drinks. He was completely all right till 1 month back when he started noticing he has cough with hemoptysis. And the scan was done. The scan did show that there were multiple mediastinal nodes which were there. There were bilateral hilar nodes which were there. There was a subcarinal lymph node which was infiltrating into the carina. He has undergone an EBUS guided biopsy from that side, which has come out to be clear cell carcinoma. So what we would do here is, and let me start from my surgery colleague. So would you consider this case as a case in which you would want to offer surgery or anything in this case?
Surgery for these lymph nodes? I don't think so. Surgery is possible in this.
So that's the bilateral hilar lymph nodes, subcarinal lymph nodes, mediastinal lymph nodes, surgery not possible. So let's say that this patient came after 9 years and had only a single upper lobe mass of, let's say, 5 centimeters, which we did biopsy and came out to be RCC. Would you consider surgery at that point of time? What I'm trying to ask you is, if the patient is relapsing after a long period of time, which are the indications in which you would consider that doing a surgery in this patient would be beneficial?
Okay, so for considering surgery in this cases, first of all is the time of relapse, how long it relapsed after the primary surgery. Secondly, what is his performance status, whether his surgery is amenable, he is able to undergo the surgery is not. So anesthetic fitness is one other thing. Then the number of metastatic sites, I think single site in a lobe, easily lobectomy can be done, and that easily he can be subjected to the surgery. So these are the factors which we usually consider.
Okay. So let's say that, and we'll come back to this later. So if you look at the risk factors, the favorable person is one in which there is 0 risk factors. So would you limit your surgery to only the favorable patients? Or you would say that selected cases you want to do surgery even in the intermediate and poor risk patients?
So if you see the risk factors, what are the risk factors, it depends on that. So suppose performance status is good, and certain things like hemoglobin definitely is a thing which can be corrected. Again, platelet count we can manage, but certain paraneoplastic syndromes cannot be managed. So I think performance status is important, time is important, and the correctable risk factors, if we could correct it, then definitely we can go for surgery.
Rohit, in your practice, which would be the patient you would refer for surgery upfront? Because what we saw in this discussion was this nice meta-analysis which did show that deferred surgery had better outcomes than an upfront surgery. And we know the results of Carmina trial, in which there were favorable patients also, but didn't matter. It was negative. So do you think there is a role for upfront surgery today?
So, sir, in my opinion, cytoreductive nephrectomy, if we are considering, then that is nephrectomy which should impact survival. That is the clear-cut thing. Palliative nephrectomy is something
that is different.
Totally.
We're not talking about that.
So again, in my opinion, sir, there is, if there is a favorable risk patient, a single met in lung, oligometastatic disease, etc., even now we can consider surgical resection for such patients. Other than that, sir, probably systemic therapy is the way.
Okay. Dr. Anand, in which patient would you be comfortable doing upfront surgery in RCC?
Upfront surgery, if it's low risk and in some intermediate risk, 1 or 2 sites of metastasis, preferably bone or lung. If I can render the patient from M1 to M0 is when we'll do. We've even done a hemipelvectomy to get margins, but 1 or 2 sites of metastasis, low, favorable, very rarely intermediate risk.
Yeah, because the problem is that if the patient has an upfront metastasis, it doesn't turn into favorable. By default, he would have one risk factor, he would go to intermediate itself. Okay, so the message is clear that you need a multi-tumor disciplinary discussion here between the medical radiation and the surgical oncologist in which patients you would want to do surgery. At present, run of the mill, you should not be offering surgery into these patients. So let's come to the next scenario. Tanvir, in this patient, he has hemoptysis and he has cough. Would you want, when the medical oncologist often they will be planning TKI and immunotherapy, to do radiation in this patient?
Yeah, so Dr. Vijay, I mean, if the patient is having hemoptysis and if you have referred the patient to me and by the time you start your systemic therapy, in that case we can plan for I don't call it a SBRT, it's a radiation conformal RT and it will be basically with a palliative intent just to control the bleeding. So it's a hemostatic RT kind.
Okay, so can you tell me that normally when we do SBRT, because how much away from the carina or from the lung tree that the tumor has to be, so that you could consider that he might be a candidate, because if there are some lung mets, if my surgeons don't think that is operable and I want to refer to a radiation oncologist, which patients would be a good candidate?
So ideal patient always for a radiation oncologist, if you look at the tumor perspective, the tumor size has to be as small as possible. For SBRT to push that dose of more than 110 BED, that is what is ideal. So the location of the tumor has to be ideally peripheral, small in size, that will be the ideal. If not, then...
Can we put a number, less than 3 centimeter?
Yeah, so now we call it something as a no-fly zone, so anything which is 2 centimeters around the carina is a no-fly zone. And then there's, if the tumor harbors in that no-fly zone, naturally your doses will be less. So that will be called as a central tumors, and there's other called as peripheral tumors. In peripheral tumors, you can push the dose, but in central tumors, you have to compromise on the dose.
So that's an important message, that if you have, there is actually a no-fly zone around 2 centimeters around the airway tree, so in which if the disease does go, you can't actually offer SBRT to these patients. And Vinay, what would be your opinion? How much dose, what fractionation you would use in these patients?
So, as he rightly said, we look for high palliation in this. If high palliation, I'm looking at high palliation, my dose would be around 40 grain, 15 fractions. So I would like his opinion. Otherwise, I've been treating with 40 grain, 15 fractions. So any other dose you follow?
So again, it will depend upon Dr. Vijay, what is your intent. If your intent is classically palliative as a hemostatic, 20 in 5, 30 in 10, anything that is good. But if you're looking in the terms of really an SBRT, then your BED of anything which is 110 and more, so you can give 60 in 8, there are multiple fractions, 48 in 4. So ultimately you look into the BED actually what. But again, intent is what matters.
Okay. Now Rohit, there are students here. Is there any RCC which you would be okay keeping on observation, not treating at all?
So yes, basically long treatment-free interval, isolated metastasis in pancreas, etc. Classically, it is described. So the point is, we can keep on observation.
Correct. Less than 2 centimeters.
Less than 2
2
centimeters.
Long
treatment, treatment.
And there's a Lancet publication to that extent, which says that around nearly you would have around 16 to 70 months before 50% of the patients would progress.
1.5 to 2 years.
Correct. You can get that near. So it's not like you see a RCC metastasis, it has to be treated. Now the question goes to, let's start with Sudip. Sudip, this patient, there is a subcarinal lymph node, which is here. You want a fast response in this patient. There are multiple choices, and I have borrowed this slide from CCO and I put the RENOTORCH data also. So which of these would be the choice of agent which you want to use in this patient who is having cough and with some amount of hemoptysis?
Sir, there are two important points. I need to downstage the tumor very fast, but the patient is 75 years old. So I am not very comfortable using with Cabozantinib and Lenvatinib.
Okay.
So for this patient, my choice will be Pembrolizumab plus Axitinib.
Okay, let's say that the patient was absolutely fit. Let's say he's 55 years of age. Then?
In that situation, for faster response, Cabozantinib plus Nivolumab.
Okay, why not Lenvatinib Pembrolizumab? Gives a response rate of 71% and 17% CR, which I know it's cross-trial comparison, but it's one of the highest response rates which you can have. is the patient who is having hemoptysis, you want fast response, and you want a good depth of response.
My understanding is that CheckMate trials, they enrolled more and more intermediate and poor risk patients than.
Yeah, you can see given those numbers also.
Yes. Yes.
Okay.
And if I use Nivo plus Cabo in first line in a poor risk patients, then I can keep Lenva for second line.
Okay, so you want to keep something for the second line. Rohit, what would be your choice in this patient? We had actually done a geriatric assessment in this patient, and this was absolutely fit patient.
I would probably go for Nivo Cabo only, sir.
Okay, you would go for Nivo Cabo.
Yeah.
And your logic would be?
My logic would be that probably a faster response is required. He is having active hemoptysis. And any progression in that area probably would be a bit dangerous.
Disastrous for the
patient. So,
yeah. Karan?
Sir, I would second that Nivo Cabo.
Okay. Okay. So now let's say that this patient did not have any symptomatic issues, and he went for a routine checkup, and we got an X-ray done which showed some nodules, and then he gets a HRCT done, and you see that there are multiple nodules, but the patient is asymptomatic. He's a 75-year-old male now who is asymptomatic, which has blood pressure, but no other comorbidities. Now, putting this situation where the patient is asymptomatic, would your choices of therapy change? And let's start again from Sudeep.
Yeah, I told earlier, sir, that if I don't want faster response, then Pembro plus Axitinib, because Axitinib is milder than other TKI. But if I need faster response in poor risk or intermediate risk patient, then Cabo plus Nivo.
Okay. Why not Neo plus Ipilimumab in this patient? Because he's asymptomatic, he's an elderly patient, you don't have to give TKI for so long, you don't have to trace his BP, don't have to see for his TSH. Give Neo plus EP?
Yes, that is also a valid option.
Okay. Rohit, what would be your choice if the patient was 75 asymptomatic?
So again, sir, if the patient is asymptomatic, 75, disease recurring after a long time, incidental, I would probably Pazopanib alone is also an option.
Okay.
Single agent TK, I won't be hesitating.
Okay.
But Nivo EP is a reasonable option in case the goal of treatment for the patient is a limited duration of treatment and you want to avoid TKI toxicity.
Karan, what would be your choice in this patient?
Sir, I have experience with Pazopanib, so I think Pazopanib is a good option, but definitely EP Nivo is one option, but I don't have any experience with that.
The only issue with EP Nivo sometimes is that quite a few patients do get progress within the first 2 months of treatment, which rapid progression is not seen when you add a TKI with that. Any taker for, no one was ready for RENOTORCH regimen. Frankly, with the cost, I think many of us would actually prescribe a RENOTORCH regimen. You presented it. What was your? We looked at the data. How do you see it with comparison to other data, especially when you look at the A leading to discontinuation? If you look at the charts, in most of the charts, the figures are from 7% to 45%, and this is one of the regimens which has a discontinuation rate of only 5.8%.
Yes, sir. With respect to efficacy compared to remaining trials, this is also did same as far as me concerned. Response rates, the except CR rates, overall response rates, PFS, everything was almost on par with the remaining trials. But OS needs to wait, but as of now, the efficacy wise, it is almost in par with the remaining trials. Adverse events more or less same, what I felt like, same more or less.
And interestingly, the trial actually recruited intermediate
and poor risk. They haven't included favorable risk.
Favorable risk patient in this group.
That is also one option.
Yeah.
Sir, probably financial issues, RENOTORCH, the current practice is 40-40. 40 Nivolumab and 40 Cabo.
Okay.
So that is the low dose immunotherapy.
I agree. The patients do respond with low dose Nivolumab and Cabozantinib. I don't see Dr. Amit here. He has a big series of such patients. Okay. Now, let's go to this data. How important for you is when you have so much multiple choices to see that two of the regimens, one of this which is I think Cabozantinib data, Nivo Cabozantinib, who has a follow-up of around 4 years, and we have this brilliant data of Neo EP which has now a follow-up of 8 years. And what you're looking at and you're telling the patient is, in this trial, as we all, if you go back to the NEO-EP and you see that the number of patients which got recruited in these patients, a high number of them, nearly 80% were of intermediate or poor risk patients. And you are telling the patient that, see, you have a 90-month survival probability of 35%, which is like 1 out of 3 patients will survive more than nearly 8 years, you could see. So how important is for you in decision making to see this long-term data? Because for other drugs, up till now, we have not got a long-term data. Any of the medical oncologists can take that question. So they will take everyone's opinion.
Yeah, sir, but the initial 2 months is very crucial.
Correct, I agree.
If one of my patient progresses in first 2 months, for him it is 100% progression. I can't show my patient these figures and curves.
Yeah, I agree, and that's the reason why they did the cosmic data in which they tried to add cabozantinib to this drug to decrease the rapid progressions which we've seen.
So probably I am comfortable to use this IO-IO combination in patients who does not have any visceral mets.
I'm not just talking about IO-IO.
No.
This neo-cabozantinib also.
Yes.
What I'm trying to tell you is, how much impact does it makes to see a long-term data in decision making as versus to when you don't have a long-term data with other IO plus TKI combinations.
It is very convincing data, so, but sir, for patients who have multiple liver mets or lung mets, so in those patients, I will choose IO plus TKI rather than IO.
So what you're telling is, if there's much of visceral disease is much and you see this heavy tumor burden, you want a rapid response, you want it not to be a rapid progression.
And not a hyper progression in the first 2 months.
Fair enough, fair enough. Rohit, any difference of opinion?
Almost the same. Yeah, same opinion.
Okay. So with that, those were my slides. So we'll open it up for the, if anyone has questions. Any questions from anyone? If no, yeah, sure.
So I'll just make 2 points regarding the cytoreductive nephrectomy, which we discussed initially. Number one, the meta-analysis which we saw, it included only two RCTs. The first one which was included, I think it was Certam. Already we have seen very flaws in the accrual of that. So, and they have, the authors have taken only 2 RCTs, all have biases in their studies. So we cannot take home the message from that RCT that like delayed cytoreductive nephrectomy is better, or as a better survival, overall survival as compared to the upfront, number one. Secondly, whatever risk stratifications we have for metastatic RCC, as far as the surgical risk, surgical operability or surgical this is concerned, I think they, most of them, as we saw in the one which you showed, like many of them are correctable at least till the time we have surgery.
So the issue why they became risk factors is not because they were correctable or non-correctable. It came via a big multivariate analysis which was done by MSKCC, where it was seen that these features, if were there at prognostic features, they lead to having a detrimental survival.
But
and this has went through, there are students here, so we need to understand that.
So
let me complete, sir.
Yes, sir.
We need to understand that each of these, when they are there, each of them independently has led to a poor survival. And that's the reason why they have been put into place. You may correct it, but the fact remains that each of them, of these criteria, have undergone a strict external validation.
I absolutely agree with you. But as far as I know, all these were studied for the patients who were undergoing systemic therapy, not for patients who are undergoing nephrectomy.
So that also is not correct. There have been studies prior to that, retrospective analysis, which came both from MSKCC and IMDC. And I can put the papers in the group so that everyone can, for the benefit of everyone, which actually showed that if you had these risk factors, which were more, the patients failed earlier.
So if you put that, I can also put some data before Certime and Carmina trial. all retrospective studies, they always favored cytoreductive nephrectomy
Sir, I understand
upfront.
your passion for cytoreductive.
No,
but
that is not my passion. What I'm trying to say is...
But we need to, let me complete. We need to understand there were 2 randomized trials which were done with all their flaws. And they did show that doing cytoreductive surgery did not lead to an advantage. So if we want to say that today we have to do cytoreductive surgery, the law would be we need to do a randomized trial, show that the cytoreductive surgery benefits, then only the community will exist. See, what we are telling is we are ready to believe retrospective analysis, which has all the biases, but we are not ready to believe 2 large done randomized trial, the PI of which, at least of Carmina, was a surgeon himself.
No, we are believing that. But what I'm trying to make a point is that given this, I don't think in real-time data, looking at our patient, my patient, your patient, any patient will not have a single risk factor.
So no, it doesn't happen.
Then anyone doesn't require cytoreductive nephrectomy.
Sir, actually, Carmina did show that upfront cytoreductive nephrectomy, even in a favorable risk factor, did not benefit. I am not denying that there is no role of cytoreductive nephrectomy. What I am telling is, it cannot be the run of the mill that every patient is subjected to cytoreductive nephrectomy. It has to go for a discussion in a multi-tumor board, but definitely not for a patient of poor risk. Some selected intermediate risk, because if the patient is a synchronous, he cannot come in favorable risk. If the patient has upfront metastasis, he will always land up in intermediate risk.
That is what I'm trying to say. So let me put it in a better way, that all the patients who have a good performance status, who are oligometastatic, who are symptomatic, suppose the patient is having hematuria, what will you do?
So that is that is not the topic of discussion, sir.
No, I'm trying to say.
Let me complete. The panel was very clear. If the patient has hematuria, pain or anything, you would subject the patient for cytoreductive nephrectomy. That is palliative cytoreductive nephrectomy. Here the discussion is, does doing the cytoreductive nephrectomy, who is a surgery for the patient, which has issues during and afterwards, would it lead to a life expectancy improvement or not? And at present the data shows it doesn't. It doesn't.
No.
That is what has been shown in the randomized study. That is what has been shown in the meta-analysis. I agree that there will be certain patients who may have limited metastasis, which whole can get operated at the point of time, which may in a multidisciplinary tumor board may go for a surgery. But it cannot be, was I repeatedly saying, it cannot be the run of the mill that every patient.
Even I am not making that point that in every patient it should be done, but there are certain category of patients which may benefit from cytoreductive.
Correct, I agree with that.
That's fine.
I
The point is well taken.
Yes, Vinay.
Coming to that, say suppose post-systemic therapy or combination of immuno and TKIs, say the metastatic sites are all responded very well.
Yeah.
Now the main volume is in kidney. So more than 90% is in kidney. So extra-renal is less than 10%. In those situations, do you...
So that is exactly what the deferred nephrectomy paper did show.
So my second question to that is, say after nephrectomy, would you continue your systemic therapy? If you are continuing, what is the point in doing surgery? Because extra-renal disease is minimal.
I think that is next. The next talk is, I think, perioperative.
No. His question is, so let me frame it. So all these trials which were done for immunotherapy, IO, TKI, and before the TKI, always required a measurable disease to be present. So these trials cannot give you that answer, that whether if you do a delayed cytoreduction, whether after that you should give or you not give. But what you do is you extrapolate the data from the adjuvant setting. Today we know that if there is a large adjuvant setting, we know that 1 year of pembrolizumab benefits. So even if everything gets operated, then I would give. If something is left, I would definitely give because measurable disease is present. Okay, I think
sir,
yeah.
These IOTK trials also reasonable number of patients underwent nephrectomy.
Correct. That is there. What I'm trying to tell is, when these patients were being recruited, you required a measurable disease to be present. So if the patient did not have a measurable disease anywhere, let's say there was only a bone met, non-measurable, they were not included in these trials. So I think with that discussion, we will thank, and I thank the panelists for the nice discussion and the audience. Thank you.